In the interest of time, folks, let's see if we can get going. Welcome to the seminar. This is a seminar for a radiology candidate. It's Dr. Casey Johnson. He is a PhD. He's a PhD from Mayo, postdoc at the University of Iowa, and a postdoc now at the Center for Magnetic Resonance here. And he's expressed interest in becoming part of a clinical department to do more integrative research in combination with basic research, and so we consider this a big deal for our department if everything works out well. And so, as you can see, the title of his talk is The Role of a Medical Imaging Scientist. I tried to get him to put physicist in it, but he was afraid it would be mistaken for therapy physicist and nobody'd show up. And so,
hey,
anyway.
I would have shown up.
I couldn't let that one go by. So anyway, Casey, we'll turn it over and welcome.
Well, thank you all for coming today. It's a pleasure to be here. This is about the friendliest audience I've ever presented for. And many of you are aware of various elements of my work, but I kind of am going to give you an overview and spend a good part of the time talking about where I've been and what I'm working on, and what I would foresee as a future research program, and then get into what I think my role would be here, particularly in the radiology section and in service to the Department of Veterinary Clinical Sciences in general. So let's start with what I have done in the past. So my work with MRI started at the Mayo Clinic, where I worked with Steve Reeder, who directs the MR research facility there. And this work was focused on high-resolution 3D imaging of the peripheral vasculature. So here you can see the arteries in the thighs, and we're specifically targeting peripheral arterial disease. And for this work, it was really sort of technically MRI driven, where we were undersampling our data acquisition and sort of these clever ways to speed up scan times, really push down our spatial and temporal resolution. And we were developing these multi-element receiver ray coils to really push our acceleration. So in these studies, we're typically doing 8x parallel imaging, so 8-fold reduction of case space, in addition to view sharing and partial Fourier and other things. So this is pretty high end in terms of sort of net acceleration you can get, whereas downstairs, you might be able to do 2x with certain sequences. But angiography lends itself well to this, and in particular, I developed a technique called fluoroscopic tracking, where this is one of my favorite examples. It's a multi-station bolus chase technique, so we're intravenously injecting gadolinium contrast material. This is the rate at which the data was actually acquired. So this is, and we had these images then displayed in real time on the scanner console, so we could watch the contrast bolus progress to the next station, and then I could press a button and tell the table to move. And that way we could catch the arterial phase along down the periphery. This patient has a lot going on, but had particularly slow flow. So this was a case where the CT angiography outstripped the bolus, and where this is a nice case where this technology could be useful. So we did patent this, and this work is continuing at Mayo. But then I wanted to pursue an interest in brain imaging and neuroscience. So I went to the University of Iowa, where I worked with Vince Magnotta, who directs the MR research facility there, and John Wemme, who's a psychiatrist and neuroscientist who's particularly interested in the role of pH in the brain. So he studies acid sensing ion channels, in particular looking at panic disorder. So we did some work using T1-Rho to look at panic disorder as well as bipolar disorder and other things. T1-Rho is a MRI relaxation time. So if you know about MRI, you can generate these T1 weighted, T2 weighted images. And this contrast is related to physical property related to the underlying tissue composition that relates to these, what we call relaxation times. So T1, T2 are pretty standard, T2 star is pretty standard. T1 row is not yet clinically available on systems, but it's a more advanced method that's similar to T2, but has additional sensitivity to certain things, such as in the cartilage, proteoglycan content. It's also more sensitive to pH, which is why we're using it in these studies, and other things as well. So a lot of my work here was running this study on bipolar disorder. This was a $2 million benefactor gift to the university to start a project in bipolar disorder and looking at population differences between people in the euthymic state or baseline state versus a group of normal controls. And then we also looked at manic and depressed mood states, and I got interested in sort of this multi-parametric imaging of getting different contrast to increase our sensitivity, so using relaxation time mapping as well as diffusion imaging and other modalities. And getting back to my time at Mayo, I was very interested in sort of this high resolution signal to noise ratio, SNR efficiency, 3D. So I did quite a bit of work there trying to make this sort of 3D T1 row whole brain mapping more realizable in this population. So this had some things to do with the pulse sequence, and then some of these sort of compressed sensing algorithms and so forth that we were working to push. Now, two other things happened during my time at Iowa. One of the reasons why I went there in the first place is they had gotten a grant to get a 7 Tesla MRI machine, but they finally got it installed about 6 months before I was ready to leave. So I never got to use the machine, but I got to see its installation. But there were many talks while I was there on ultra-high field MRI, and that was always part of the motivation in terms of what I was working for. So that was something I was always interested in working on. And toward the end of my time at Iowa as well, I got involved in new but potentially really cool project to use T1 row imaging in a mouse model of Huntington's disease. And this is showing T1 row maps in Huntington's disease model versus the control. And this was looking at a therapeutic intervention, and we actually got funding for this project, internal funding, and I had prepared an R21 for this, and we were ready to push on this, but then I took a new job, and they never did anything more with this project, which was a shame. But I think these experiences really kind of set the backbone for what I'm interested in from a scientific perspective, and in particular in MRI technology development and application perspective. So things like 3D high resolution efficient imaging, quantitative imaging, multi-parametric imaging, trying to make these methods robust, have high spatial fidelity, quantitative accuracy. Pushing the ultra-high field MRI is a method to increase sensitivity and spatial resolution due to the nature that ultra-high field MRI has a higher signal to noise ratio. Looking at contrast mechanisms, developing new ways to more sensitively or specifically detect disease. So T1 row is one of those such mechanisms. Utilizing animal models, clinical translation, and then interdisciplinary collaboration. So I then had the opportunity to join the CMRR here on campus. So this is a big-time MRI research center. It's one of the biggest in the world. It's directed by Camille Ugerbill and co-directed by Mike Garwood. It has about 40 faculty that are PhDs, all doing MRI research in some technical capacity. An additional 75 or so scientists and staff. The major emphases are ultra-high field MRI, both brain and body imaging, as well as a general large emphasis on brain imaging and spectroscopy, and as well as people focus on engineering solutions like developing the hardware and coils to utilize these systems, and novel acquisition schemes such as T1 row or many, many other things. So at CMRR, they have 3 Tesla MRI scanners, 2 7 Tesla, preclinical 9.4 and 16.4 Tesla scanners. These are all fully research dedicated, although they do have clinical cases run on these systems as well. And then they have the world's first 10.5 Tesla whole body system that they are currently doing their FDA approval safety studies on with volunteers, but we'll soon be opening that up to regular research. So at CMRR, I joined a team focused on musculoskeletal research. This team is led by Jutta Ellerman, who's a musculoskeletal radiologist. And for some time, it was just Jutta and me, but we recently added a couple new people to the team, Stefan Spin and Kai Ludwig. And this group is primarily, if there's a theme that we're focused on, is developmental joint disorders. So diseases of the developing skeleton that in particular are precursors to osteoarthritis and long-term disability and dysfunction. So those 3 diseases that we primarily work on are osteochondritis dissecans, or OCD, Lake-Half-Perthes disease, and femoroacetabular impingement, or FAI. And I'll say more about each of these. Now, this work wouldn't be possible without very strong collaborators in other departments and with diverse expertise. So this is one of the reasons why I took the job in the first place, and one of the reasons why I'm so interested in potentially coming here and working with people, is I really like the interdisciplinary nature of this project. So I've worked very closely with Kathy all these years, Ference, and then there are many other people as well that I've had the opportunity to interface with. And I think we're doing some really great work that wouldn't be possible for just an MRI scientist to do or just a radiologist to do. So going back to sort of the focus of the work, developmental joint disorders that are precursors to osteoarthritis. There are many challenges with these diseases. In general, they have unknown etiology, they have a complex pathogenesis, and clinically it's hard to know if, when, and how to intervene. So our goal is to try to understand these things and inform clinical management of these disorders. Shown here is a diagram of a growing femoral head, and just to orient you to some of the relevant features, here is the growing bone, which we call the secondary ossification center, that receives a vascular supply. You then have overlying this epiphyseal cartilage that is gradually replaced by bone through a process called endochondral ossification. This epiphyseal or growth cartilage is vascularized, unlike the overlying articular cartilage, which is avascular, and in an adult joint, articular joint is the cartilage that remains. So in these diseases, you can have interruption of this blood supply or other things that can interrupt this process that can result in joint deformities and other issues. So on an MRI, this is a femoral head specimen, and here I kind of use these labels throughout my talk. This is the secondary ossification center, metaphysis, and here's the epiphyseal cartilage, and then on the top, the bright line is the articular cartilage. So I wanted to say a little bit about OCD. This is the primary project I was brought in to work on, and this is now an R1 funded project. And Kai and Stefan, the new people on the team, are really kind of taking on this work at CMRR. But this is a developmental joint disorder that primarily affects the knee. You've probably heard about it if you know anything about what Kathy has worked on. But what can happen is you have these sort of bony lesions here in the distal femoral condyle, and these are at risk of breaking off and damaging the cartilage. So clinically, these kids are presenting, at a fairly late stage. But really, nothing is known about how this lesion materializes, whether or not this lesion is going to progress. And these are questions that we are looking to answer in using MRI to help answer this. So if we focus on this area here, and if we go to Kathy's work, she spent a large part of her career studying this process of interruption of the vascular supply to the groin epiphyseal cartilage that can occur naturally in animals. So animals also have OCD. So it provides a really nice comparative species to try to understand the etiology and pathogenesis of this disease, which we don't generally see children coming in with subclinical lesions. So what happens is you can have interruption of the blood supply in the epiphyseal cartilage, which can result in cartilage necrosis, or what we call an OC latens lesion. This cartilage area, or this necrotic area, can lead to interruption of the endochondral ossification and creates a point of weakness such that you can result in these cartilage injury later on. And this is what is clinically known as an OCD lesion in veterinary medicine. So one of the things Kathy was interested in was whether there was a way using MRI to image these vessels in the articular cartilage or the epiphyseal cartilage in a 3D manner, something that could potentially be assessed in vivo. And this is really what started this collaboration with CMRR and was sort of the impetus for a lot of the work that was to follow. And I want to make sure I mention these because I'm now looking to utilize these same techniques in my work at the hip. So this technique, susceptibility weighted imaging, is very sensitive to these cartilage canal vessels, and you can see them outlined here very nicely in a goat, in a human, and in a pig. These are ex vivo specimens imaged using our 9.4T preclinical system. And this, if you process these, you can make very nice images that look like this, where you can really see the detail. This is a 1-month-old human cadaveric specimen. You can see the detail of the vascular supply in the epiphyseal cartilage very well. So we're looking to use this technology to look at kind of the origins of OCD in animal models and in humans as well. For the next step of the disease, this early cartilage necrosis, it turns out that these relaxation times, such as T1 row, are very sensitive to these areas of ischemic injury. This was an induced lesion where Ferenc cut the vascular supply in the epiphyseal cartilage, and then the animal went on to have these islands of chondronecrosis. So MRI is a very sensitive method for this early ischemic injury of cartilage. Now Ferenc has continued this work and is actively trying to develop an animal model of OCD that really mimics the human disease. So these are images acquired here at the vet school using your 3T scanner. And this is a longitudinal study over the course of about 12 weeks following the progression of this early cartilage lesion here. Now, one of the cool things, or a project that we're looking to do, which I think is really neat, and Ferenc has submitted a grant to do this, is use our 7 Tesla MRI to really try to push spatial resolution and signal to noise, where potentially now, with pre-surgical imaging, we can identify where these cartilage canals are, and then Ferenc can have a nice 3-dimensional picture of which vessels he's cutting, and we can relate that then to lesion progression. And we can come in with our quantitative mapping sequences and so forth and really follow how these lesions progress in great detail. So I think this is an exciting avenue and is one example of how I think we can utilize resources at both sites. On the CMRR side of things, our work is primarily focused on the human disease as well as developing new imaging tools. So we're working things on like quantum susceptibility mapping, these relaxation time mapping techniques, diffusion, perfusion, ultra-short echo time, sodium imaging, ultra-high field. So I'm hoping that as we continue on, these tools become available for these animal model studies as well. So that's sort of what I have done. Now I'd like to talk about what I'm currently working on, which is related to my KO1 award, quantitative MRI of developmental hip disorders. So the first disease I want to talk about is Perthes disease. So this is the same team as before. It emerged kind of from the OCD project, but we have a key collaborator here, Harry Kim, who's a pediatric orthopedic surgeon at Texas Scottish Rite Hospital for Children, and he's one of the leading clinicians and researchers for Perthes disease. He also has a piglet model of Perthes disease that he's evaluated extensively, and it's the most well-established model. So this provides a means to study the pathogenesis of Perthes disease and potentially identify new imaging markers to investigate this. So Perthes disease is, as I mentioned, a developmental hip disorder that can result in severe femoral head deformity to the femoral head. This can happen, the disease can start in children anywhere between the ages 4 up to 14 or so. And what happens is that for an unknown reason, the blood supply to the growing femoral head is interrupted, and this leads to extensive bone marrow and cartilage necrosis. However, at a later time, the femoral head will later spontaneously revascularize through the formation of new vessels penetrating through the epiphyseal cartilage, and this starts a reparative process where there's first bone resorption, which actually weakens the femoral head and makes it susceptible to deformation and collapse, and then later reossification with new bone formation that can strengthen and repair the femoral head. So clinically, deciding how to intervene, when to intervene in these patients is difficult using existing X-ray based and conventional MRI based tools. So we're looking to develop 3D quantitative MRI techniques to look at these different stages of the disease. This is a disease that also happens in dogs, and here's an example shown here. So I want to highlight some research that I've done in this area. So first, looking at the early ischemic stage of the disease, radiographs can often appear normal at this early stage. So clinically, what they do is contrast-enhanced MRI. But this is falling out of favor due to concerns about gadolinium toxicity, particularly in pediatric patients, and particularly if you needed to do serial acquisitions to follow if the femoral head is reperfusing or not. So we're trying to develop, again, a 3D quantitative non-contrast enhanced technique that is sensitive to this early ischemia, not only in the SOC, but also in the overlying cartilage as well. So one solution would be quantitative relaxation time mapping. We know it's sensitive to ischemic injury in the cartilage, maybe it's sensitive to the bone as well. So this was a series of studies we did using the piglet model. And so how this model works is you place a ligation band about the femoral neck and transect the ligamentum teres. And this completely cuts off the blood supply to the growing femoral head. So the metaphysis here is unaltered, and it's only the femoral epiphysis that has this reduced blood supply. So you do this on 6-week-old piglets. And here's an example of a femoral head 4 weeks after surgery versus the contralateral control head. So in the initial study, we had Harry Kim do the surgery on animals at Texas. Then he froze the specimens, sent them to us. We imaged them at 9.4 Tesla MRI. So we did a pair at 48 hours and then a series at 4 weeks. And here is what we saw. So this is looking at a number of different relaxation times. And what you can appreciate is, in particular with T1 row and these more advanced variants of T1 row, we see a large increase in this relaxation time in the operated versus the contralateral controlled hip. And this is 48 hours after surgery. So this is a monster effect. This was about 100% increase in relaxation time. Usually you would see, T1 row effects in other conditions, they're looking for things on the order of 5% or something. So this is a huge change, and it was frankly a little bit hard to believe. And I kind of wondered if maybe freeze-thaw has some effect here, what's going on. So we did a second study where Ference now implemented the model here so we could image freshly harvested femoral heads. And we tried it again, and we saw the exact same effect. So this was in 6 piglets for, again, 48 hours after surgery. And T1 row was, again, the most sensitive of these methods. And I did this study both before and after freeze-thaw, and the effect was the same. So freeze-thaw had nothing to do with it. So this is strong evidence that this is potentially a translatable method. It is a real effect. So then we went to the point of, now can we image these pigs in vivo at 3T? So we just started doing this a month or 2 ago. And this is now a couple of pigs imaged with T1 row and T2 mapping, pig 1, pig 2, and you can easily tell which one is the ischemic side. So this is really compelling evidence that T1 row might be an early measure of this ischemic injury and may relate beyond just to Perthes disease, but to bone avascular necrosis, ischemic injury in general. The other key point here is if we got histology on all these to verify that these femoral heads were ischemic. And one thing that's pretty interesting is, at this 48-hour time point, there really isn't macroscopic changes on histology between the operating and control. It's really more intracellular in terms of having some necrotic neurocells. The bone is still viable. The injury to the cartilage is really limited, to the chondrocytes is really limited to the deep layer of the epiphyseal cartilage. So this suggests that there's something about the process of necrosis, and we don't know what's driving this, but this would be something to investigate. There's something during the process of necrosis that's creating this huge change in our relaxation time. It could be acidosis, it could be some sort of change in water content or a molecular change. But this is an area we're really interested to investigate moving forward. Another element of this Perthes project is looking at this early revascularization stage, see if we can detect the onset of revascularization. Harry Kim has previously shown using micro-CT, which is only available ex vivo, that the revascularization occurs through the formation of new vessels penetrating through the epiphyseal cartilage from the margins, what I'll call the margins of the epiphysis. And if you look at human patients using contrast-enhanced MRI, here's a serial contrast-enhanced exam. You can see the vascular reperfusion coming from the sides, just like Harry showed in this model. But you can't see the cartilage in these cases, and so we thought, well, maybe this quantitative susceptibility mapping might be a method to look at early cartilage revascularization. So we tried this on these ex vivo piglet femoral head specimens. So here's an example. Here's the control and the operated femoral heads 48 hours after surgery. Now QSM is sensitive to these vessels whether or not there's blood flow. It's more sensitive to the overall structure of these vessels. So in this case, 48 hours, there's really no difference between these. And you can appreciate that here in these rotating maximum intensity projections, that these two really look the same. But if you look 4 weeks after the surgery, which is when it's known this early repair phase begins, now you start seeing some substantial changes. So you can see increased vessel density at the margins of the epiphysis, and you can see these sort of branch-like structures here. Excuse me. They're a little bit easier to see in the rotating nip. So now you can appreciate some pretty substantial differences between these femoral heads. So if you look at histology, this is what these vessels epiphyseal cartilage vascular canals look like normally, but here in the operated femoral heads we saw these burst patterns. And this is what they look like on the MRI in more 3D depiction. So this is the signature of neovascularization, so we're pretty confident we have a method that can detect neovascularization and have a method to show that revascularization is occurring. Excuse me. So a couple other things we're looking at with this project. One is going to the repair stage now. So when there's revascularization, can we detect changes that are occurring within the bone and or the cartilage? So here's an example of one of our quantitative maps that we have both a necrotic area, and this is 4 weeks out. There's also a region of repair. And interestingly, these relaxation times are now going down in the region of repair, so we're hopeful that not only can we detect the early ischemic injury, but also the subsequent repair phase as well. And then we're starting to look at techniques to do bone imaging using MRI. In particular, techniques that can directly detect signal, water bound to bone, and that might be sensitive to new bone formation. So to summarize the findings from this project, we showed that this quantitative relaxation time mapping, in particular T1 row, is sensitive to this ischemic injury in the femoral head, and this might have ramifications not only for Perthes disease, but also avascular necrosis in general. We can also use this quantitative susceptibility mapping technique to detect these new vessels in the epiphyseal cartilage. And it might be useful clinically, but it's also useful from a preclinical studies standpoint, where Harry, for example, is investigating proangiogenic treatments to try to promote earlier vessel formation to speed up the repair phase. So this might be a method to see whether his treatments are working. And then for next steps, we have ongoing in vivo studies. We're looking at clinical translation, running imaging patients with Perthes disease at Texas and at here, looking at the T1 row contrast mechanism, as well as these new repair phase imaging techniques. One project that has come out of this work, because we saw this, quantitative mapping is very sensitive to this ischemic bone injury, and we're working on these bone imaging techniques and so forth. One idea is to potentially use these to help characterize bone tumors. This is a project for which Jessica got a CVM grant to look at. So now we're going to look at post-mortem canine limbs that have spontaneously occurring osteosarcoma and image these at CMR using some of these advanced techniques that might help with the radiomics side of the radiation therapy. So the other project I want to mention, which is, so that I should say that LCPD project, AVN project, is sort of the first aim of my KO1 work. I have two aims of my KO1. The second one is related to femoroacetabular impingement, which LCPD can ultimately result in impingement-like syndrome, but this is a more common disease in which you have some deformity to your hip joint, whether a common one is what they call a cam deformity, where you have some sort of abnormal bump on the femoral head, and as someone uses their hip joint, eventually you get wear and tear against the cartilage, particularly on the acetabulum side. So you have your acetabular cartilage as well as your femoral head articular cartilage, and around the acetabular cartilage there's the labrum, which is also can be torn and it can be very painful. So there's a lot of interest in developing or using hip preservation procedures to potentially offset or prevent or delay onset of osteoarthritis and further damage. So I should mention Patrick Morgan is a hip arthroscopist. I can't say it. He's doing hip preservation surgery at the University of Minnesota. So he's a primary person doing these surgeries. But one of his challenges is he'll go into the joint and then he'll see, you know, the MRI says it's mild damage, but then he goes in and he sees the damage is too severe to really correct it. So he just gave the patient unnecessary surgery. So there's interest in developing techniques that are more sensitive to early damage to the cartilage and the labrum and subchondral bone. But imaging FAI has many challenges. You need sensitive markers to the early injury. The spatial resolution of the acetabular cartilage is very small, 1 to 2 millimeters. And then there's the issue of clinical feasibility. Can you do your imaging efficiently, robustly, with automated post-processing to get the result to the surgeon? So Jutta Ellerman and Patrick Morgan did a study before I got to CMRR, looking at correlation of T2 star mapping, which is another relaxation time mapping method, with arthroscopy. And what they showed is if they grade over the extent of the cartilage and try to identify where the damage is, they get really nice correlation, particularly between a completely normal cartilage versus cartilage that is mildly or severely degraded. So this is sort of the motivation for the project. Now I want to come in with T1 Rho, T2, some of these advanced methods, as well as push ultra-high field MRI. So as I mentioned, 7 Tesla provides increased signal to noise ratio, which allows you to push spatial resolution and may help improve detection of this early injury to the cartilage and or labrum. So here's an example of the 7 Tesla hip image. You can see this doesn't look very good. In this case, I was interested in imaging the right hip here. And for this, we're using a 16-channel transmit receive loop dipole coil array, which is a pretty complex thing. But what you can do at 7 Tesla, or I should say one of the primary challenges, is you have these areas of what we call B1 inhomogeneity, or these local regions of signal dropout. So you can correct for this using a technique called B1 shimming or parallel transmit, where basically you use signals from different transmitters and you combine them in such a way that you recover a signal in your region of interest. So you can see here with B1 shimming, we now have much better signal in the femoral head of interest. And so here's some of our examples. We can do our standard 2D spin echo imaging as would be done clinically. We can get really nice 3D images with high resolution. And we're working on things like bilateral hip imaging, really pushing the spatial resolution as well as quantitative imaging. So this is sort of the next phase of the project, heading into years 3, 4, and 5 of my K01, is trying to develop these imaging tools for this and other applications. You know, I think one application area relevant to veterinary medicine that could benefit is hip dysplasia, where it's, you know, a lot of these techniques from both the Perthes project and this project could really benefit that application. So that might be something I'd be interested in driving toward in terms of going after R1 funding. So I'd like to take the last bit here to talk about what my role would be, or as I envision it, in the radiology section here, as well as in the department, given that background. So I really see myself contributing to three major areas: research, infrastructure, and human capital, or the value of that people provide to the section and the department. And although, you know, my service and contributions will be primarily to the radiology section, you know, I certainly hope that these tools and so forth are useful to the department, the college, and the academic health center as a whole. So let's talk about research. So this is, I think, probably the most important thing and most urgent thing I need to do is build an R1 funded research program. This is the purpose of my K01 award, and this will really allow for a backbone to do many of the other things that I would like to do. So In terms of an R01 research program, I envision a program that really has three components. It's rooted in technology development. I then want to validate those technologies to show their feasibility and utility. And then I want to translate them to clinical applications. So I want to work closely with clinicians and others to try to ultimately use these new tools I'm developing. Additionally, I want to work closely with clinicians because I want to develop technologies that are ultimately useful. So I want my research to be informed by where the need is. So I think one of the first things I do if I were to come here would be to understand what you are all interested in, what you're working on, where the needs are, and then try to tailor my technology focus to fit those needs. In terms of technology development, I mean, here's sort of a list of the things I'm currently working on and generally interested in. Quantitative mapping, novel contrast, ultra-high field, imaging low signal tissues, efficient and robust imaging, but it's broader than that too, looking at faster imaging, you name it. In terms of applications, I'm open to pretty much anything. For feasibility and utility, I'm interested in imaging ex vivo, having gold standard comparisons like arthroscopy, histology, using animal models, or doing veterinary animal or human patient studies, and then looking at things like treatment efficacy. And then for applications, given that my K01 is rooted in MSK, and that's what I've been focusing on the last 4 years, this is where I try to drive for my own R01 grants. The first area would be avascular necrosis, looking at these methods for early detection of marrow and bone ischemic injury and potentially monitoring of treatments. Osteoarthritis would be a big one. So hip dysplasia could fit into this context, as well as some of these other disorders. But again, kind of focus on early detection of joint injury and informing joint preservation procedures and monitoring response to therapies. And then low back pain and looking at intervertebral disc health is another area I'm interested in. And I have a young investigator in the Department of Rehabilitation Medicine, Erin Ellingson, who I have been working with on this project. But I think there are many other potential areas of interest, and I think one advantage to this position in general is I'm not limited to MSK, but I can work on a lot of diverse things and utilize my background in brain imaging and other areas. Like looking at things like cancer, neurological disorders, cardiovascular disease, you name it. But these might be areas where I help other investigators really push their work forward. So research, building R01 funded research program that's interdisciplinary, highly collaborative, highly translational. In addition to that, I want to support collaborations and clinical research in the radiology section of the department and help people get funding and resources, help implement new imaging tools. Ultimately, if I'm funded, I can bring in new personnel that can additionally help, or if there are other ways I can support people with their research. And then I think also helping students, interns, residents, and postdocs with their research projects, whether providing opportunities for research, guidance, mentoring, or collaboration. The other section here is infrastructure. So one major area where I think I could contribute is on the equipment side, so in terms of information gathering, providing technical input, and in terms of writing equipment grants and trying to help get funding for these systems. I know the section is funding to get a dual energy CT, which is fantastic, and I know that this section is also interested in upgrading the MRI machine, and I think there's interesting possibilities here. I've worked with both GE and Siemens systems, and both are great. CMRR is running all Siemens systems, so I think there is a unique opportunity to potentially get a Siemens machine and really be able to bring techniques from CMR here at the vet school, have a place where an additional 3T scanner on campus that's partially at least research dedicated that investigators can use and potentially do their studies here. You know, CMR is a animal-human center, but I can say from my own experience, if we could image these animals, whether spontaneous disease or induced disease models here, that would be really, really fantastic. And the primary barrier is that the MRI machine just doesn't have the right sequences, it doesn't have the right hardware to really do these things. So I think that's one area that should be explored. Another way I can contribute is access. So utilizing CMR's resources. So with Ference and my work, we have kind of established a workflow where we're now working with the CIC here, so Kathy and Sarah and the staff we're doing surgeries here at veterinary medicine, and CIC is doing the anesthesia, but then they're also coming over to CMR and handle all the anesthesia there. So I think that's great from a workflow standpoint. I think it's great from an animal welfare standpoint. And I'd like to continue to form those bridges so people can use these systems. So we can image animals using 7 Tesla MRI or even 10.5 Tesla MRI. So these types of workflows, as well as protocol development. So if you want to do glioma imaging at CMR, I can help you set up a protocol here and kind of match it to the protocol at CMRR and match it to what's downstairs at the hospital here. And the last section, human capital. I think, you know, in terms of, you know, building up the radiology section, I think one almost has to have a build it and they will come mentality. You know, I think the type of people that are going to be attracted to work here are going to be people that are academically driven, that want to do research, that want to teach. And in order to do that, you know, the salary alone might not be convincing, so there needs to be other things that really get them on board. And so things that come to mind is being a top veterinary medical imaging service, having a top training program, having state-of-the-art medical imaging equipment, having exciting research opportunities, having technical expertise that I would bring to complement the clinical expertise, and also having prominent collaborators, so there's lots of exciting research to work on within the section and the department. So I think, you know, in terms of human capital, whether it's attracting the most academically driven residents, whether it's getting new radiologists or attracting the top researchers, I think these are, you know, what I want to do here will help drive this. And then the other area is education. So I think for teaching, this is something a way I could serve the section, teaching the technical aspects of medical imaging across the different modalities, as well as medical image processing. And certainly on the research side, you know, all things related to research, be it doing the experiments, writing manuscripts or grants, responsible conduct of research. This is what I've been training for quite a while. And then mentoring. So I am very interested ultimately in taking on my own students or postdocs, as well as working with people in the section or in the department or elsewhere to advance their research projects and their careers. So to summarize, I think there are many ways in which I can contribute in this role, be it on the research side or the equipment side or helping attract people here. And I think it's a really unique opportunity for me as well in terms of building a research program. And I'd like to acknowledge a lot of people. I'm very fortunate to have great collaborators throughout my time here. In particular, I'd like to acknowledge my K01 mentoring committee, which consists of Lisa Ellerman, Mike Garwood, Kathy Carlson, and Gary Kim. I'd also like to thank Ference in particular, who has been my primary collaborator on many of these projects. And many of the people here at Veterinary Medicine as well. So thank you very much for your attention.
We've got a few minutes for questions. Anybody got any questions for Casey? Nice talking to them. Thank you. Well, I guess I would bring up one just I mean, the kind of techniques that you're using, do you think you could get into the hypertrophic synovitis and the immune-mediated joint diseases with this stuff and image the synovial tissue as well as the cartilage as well as the bone?
One could try. I don't know. I haven't seen research looking at that. I think there, in general, like with ultra high field, there's a question of how much can you push it. I think one great thing about imaging animals is that they're anesthetized. So as long as, it's not getting too long, they are going to hold still. So in terms of trying to see a very fine detail and really get down to sharp resolution, I think it's actually very advantageous. So animals might be a great way to start to look at some of
that stuff.
Yeah.
Do you have any previous or current experience teaching a clinical curriculum? I don't know, teach any courses at all?
Well,
or I guess even not clinical.
Yeah, so I mean, very limited, just because my job has primarily been to push research and grants and papers and this kind of stuff. I have done some teaching when I was a graduate student. I'm occasionally invited to give a lecture on this or that, kind of that level. Yeah, but it's always been something I've been interested in. Both my parents were teachers. My sister is now a teacher. So I don't know, it's something I think I'd be very passionate about, and I would work to better my abilities as a teacher and mentor throughout my career.
Any other questions?
Seems like this might be an excellent tool to look at organoid disease, and maybe, there should be some research money in that, not R01 maybe level, but something interesting.
Well, not everything needs to be R01 level. So every little bit helps, certainly. And I think the more applications there are that, these types of tools can benefit, then, that just creates more and more motivation and drive to move this forward.
Okay. Well, let's give him one last hand. Please fill out your comment form.
What were you on that? It's like $25 so hopefully we can work on getting because I think what we need is people